inflammation from your diet was slightly elevated. Okay? So some things that we can do is work on some anti-inflammation from your diet, an anti-inflammatory diet, fruits and vegetables, and more fish oil.
What's up, fertility fan? Let's get these babies, ladies.
It's 4 o'clock. Of course, there's some dog howling downstairs, so now Justice wants to howl. I'm waiting for the doctor to come on here. Come here. Hey fam, we're gonna go back in time for a minute. This is March 7th. I filmed this, it was the day after my uncle died, but this is my initial talk with Dr. Thornton where he explains my immunological report and what medications he's prescribing and why. I thought this would be helpful. Oh, here he comes. Hello.
Hello, young lady. How are you?
I'm well. How are you? Can you hear me?
I can hear you perfectly.
Awesome. How are you doing?
What's going on? Where you been all these months?
Oh my God, where haven't I been? I don't know if you got the note, so they had diagnosed me with endometritis. So I had to do 3 biopsies. So I had a hysteroscopy and that's when I got diagnosed. So they gave me doxycycline for 21 days. And then I did another biopsy. It came back positive again. So then I had to do Cipro and I think you said flagyl. Some really bad. Okay. Really bad. Wiped out my whole GI. It was horrible. Then I got biopsied again in December and it was fine. And then the clinic closed in December. So I got in January I got the okay to move ahead. So, and then it took me a month to get on your calendar.
My goodness. Well, here we are. Let's, what I'll do is just kind of go over the things that we saw as far as your immune and the recommendations that we see. And did you get a copy of your report already?
I did. I don't understand much of it, but I did get it.
Okay, so what I'll do is I'll go through the highlights for you. So the most important thing about your report is that when you look at it on page number 4, it kind of tells you about the assessment that we did and then the treatment recommendation.
Okay.
You look at everything, you look at tolerance, then we look at your individual assessment, we kind of come up with a conclusion of what we think could be going on, and then we make recommendations based upon that, okay?
Okay.
So the first thing we're going to do is look at and we'll come back to the recommendations at the end, you don't mind?
I do not.
But we want to look at your receptors. So there are a couple of types of receptors that are in the uterus. There are receptors that will suppress the immune system and receptors that will activate the immune system, thus rejecting an embryo. And the receptors that will suppress the immune system is the KIRAB receptors. Receptors that will activate the immune system are KIRAA.
KRIAA?
Right, that's correct.
Okay.
So what you're gonna see that on your profile there, your receptors are KIRAA. Okay.
Okay. So they're activating an immune response to the embryos.
That's correct.
Okay.
The next thing that we look at is there's something called a HY immunity, which is on page 7. And what a HY immunity means is that women who have had a male child and they carry this HY immunity antigen, the next time they try to get pregnant, or it becomes more difficult, either they have difficulty getting pregnant or they have miscarriages, because when they carry this allele, they have a male child, they will generate these antibody responses. And these antibody responses for the next pregnancy, they start attacking the pregnancy, leading to miscarriages and not being able to get pregnant. Women who just carry this HY antigen have a higher risk of miscarriage than women who don't.
Okay, and so I have it?
You have it, yes.
To my knowledge, I haven't carried a male child, though. Would that include miscarriages?
It'll be to term.
To term, yeah, I haven't had a male child to term.
I know, but those women who carry it, when you look at the data, they have a higher risk of miscarriage due to the immune system.
Okay.
So this is also suggesting why you may be having the losses that you have.
Okay.
The next thing that we look at are what's called HLA antibodies. These HLA antibodies should not be circulating in your system unless you had a baby at term or you had a blood transfusion.
I have had a baby at term.
Okay, so having a baby at term means you will have some of these circulating antibodies, which is perfectly fine. And then we look to see what is the concentration of the antibodies. And what you'll see is that one of your antibodies for class 2 is most of them are at a low concentration, but you have one of them that's at a higher concentration. So when you see antibodies at a higher concentration, they can generate this immune response, okay, and that can lead to a loss.
Okay.
Okay. And then we look at the rest. Your chromosomes on page 9 are normal chromosomes. MTHFR, which I'm sure you already know about your MTHFR, you have one mutation in the MTHFR, but the most important thing is that your MTHFR activity is nice and healthy.
Okay.
So you may already be like on a methylfolate, things like that, but
yes,
it's not necessary because your percent activity is really good.
Oh, okay. So I don't need to take the folate.
Yeah.
Okay.
When we look at the marker for MTHFR is your homocysteine. So people who have a problem with MTHFR, they have high homocysteine levels, which can lead to inflammation. Your homocysteine levels are normal.
Okay.
Now let me kind of back up just a little bit. It doesn't mean you don't have to take the methylfolate. You need some folate, okay? But you don't have to have high doses of the folate.
Okay. So no folic acid continue. I'm doing 1,000 microgram, I think, of the methylate. So
that's perfect. That's enough.
Okay.
No more than that. Okay. Excellent. So the next thing that we look at is there any increased risk for blood clots for you? So on page number 12, we look at what's called plasminogen activating inhibitor. Your plasminogen activating inhibitor was normal. We looked at factor 2, which is on the next page. Your factor 2 was normal. Do you have your report in front of you? If not, let me do this.
I'm making notes on it. I was going to pull it up, but I don't have it in front of me. I'm just referencing what you're telling me. Are you going to share your screen? Nice.
Yeah,
okay.
You have technology. Can you see my screen okay?
I can. Thank you.
All right, good. So that's your factor 2, which was normal. And then we look at what's called factor 5. Your factor 5 was normal. These are all things that increase blood clotting and decrease the blood supply to the placenta. That was all normal for you.
Okay.
Your PT, PTT, platelet counts were all normal. And then we look to see, do you carry any autoimmune risk factors that put your risk for having immune issues? So you do carry a couple of the genetic alleles that put you at risk for Hashimoto's and potentially for antiphospholipid antibody syndrome.
Oh, wow. Okay.
It doesn't mean you'll get it. This means that you have the potential to develop it, okay?
Okay.
Next, we look at what's called antiphospholipid antibodies. These can decrease the blood supply to the placenta. Now, technically, your antiphospholipid antibodies should be completely normal. You have one of them, which you see right here, the anticardiolipin antibody IgM, is in the indeterminate range, okay? So slightly elevated. Okay, but that's just something that we kind of follow. But remember, your risk factors that you do have a higher risk for antiphospholipid syndrome. So what we do in these cases is that we try to prevent these from playing a role in causing issues. The way they can cause the issues by increasing or decreasing blood supply to the placenta. Okay.
Okay.
So one of the things that we're going to recommend for you is to use a baby aspirin. Okay. As well as a blood thinner called Lovenox. You may have already been on that because that's usually a standard treatment when somebody has miscarriages. But with your antiphospholipid antibodies indeterminate.
Okay. No Lovenox. I have been doing the 81 milligram aspirin, but no, I haven't had any experience with Lovenox.
Yeah, so we recommend Lovenox for you.
Okay.
Looking at other antiphospholipid antibodies, they're all normal, no issues there. Now we come to looking at your immune system overactive. These are called antinuclear antibodies, and your antinuclear antibodies are all normal.
Okay.
No issue there. Get across the board. And this is looking for rheumatoid factor. Your rheumatoid factor was completely normal as well. Now we look at your thyroid function. We look to see, do you have any anti-thyroid antibodies? Your anti-thyroid antibodies were normal. Your TSH was nice and normal, 1.16, so no issues with your thyroid.
Nice.
Your platelet count, white blood cell count was normal. We look to see, is there any increase in inflammation? Looking at your immunoglobulins, and your immunoglobulins were completely normal there. And then complement, what complement is, if your immune system's overactive, they eat up a lot of this complement, so your complement levels would be very high. Your complement levels were normal. And then important is a inflammation to anti-inflammation ratio, like a little seesaw. And you want that ratio to be nice within normal range, and your ratio is in a normal range.
Okay.
The killer cell activity, you worry when your killer cell activity is high, your killer cell activity was low, it's perfectly fine. T regulatory cells are cells that have to be recruited in order for the placenta to develop properly. You want to make sure that you have a normal level of T regulatory cells from the beginning so you can recruit a lot as the baby grows, and your T regulatory cells are good. We look for any evidence of PCOS, no evidence of PCOS. Everyone's testosterone level goes down as you get older, total testosterone, but you'll see your free testosterone level, which is here, was nice and low.
Okay.
Hemoglobin A1C level was normal. And then we look at your nutrition, your vitamin D levels were fine. Your folic acid levels were good. That's what I was saying. You don't need the 1,000 micrograms is perfect. And then we look at your diet. Is there any inflammation coming from your diet? It's like these are fatty acids, and your fatty acids were elevated, which means that you do have some inflammation coming from your diet, which can decrease implantation, lead to miscarriages. So the recommendation for this is to take in more fish oil, okay, to bring those fatty acids down. And we'll go over the dosages in a minute, but
is it we're trying to balance the omega-3 and the omega-6? I'm out of balance. Is that what it is?
yeah, basically you want to add more of the omega-3s
Okay.
to bring down the fatty acids. And then your leptin levels, which is also a marker of inflammation in your diet, was slightly elevated. Okay. So some things that we can do is work on some anti-inflammation for your diet, an anti-inflammatory diet, fruits and vegetables, and more fish oil. Okay.
Okay.
So when we look at everything overall, the only thing that we see that is, an issue is your KIR receptor, and this is the KIR receptor we see here. Okay.
Okay.
AA. Okay. And then the other thing that we see that's an issue is that you do have some of these class 1, class 2 autoantibodies that some in a high concentration. Okay?
Okay.
So when we look at treatment, and the treatment recommendations based on what we see, the first thing that we're going to look at is, number one, we take everything into clinical account. Okay, I just got off with someone who's never had a miscarriage, never had failed implantation, but for some reason did an immune panel. So a lot of things on the immune panel, but I said, I don't know what this means for you, because clinically you haven't demonstrated you have an issue.
Right.
So we look at the clinical picture as well as the immune profile to make some recommendations, okay? So when you have the positive antiphospholipid antibody, and with your history of 3 losses, this is when we start recommending that blood thinner, which is the baby aspirin as well as the Lovenox.
Okay.
You have the presence of the HY restricting allele, which puts you at higher risk for miscarriage. You have the anti-HLA antibodies. You have the KIRA receptor. And based upon this, the best treatment for all those things in combination is IVIG.
And what's IVIG? I know it's intralipid related or adjacent.
IVIG is immunoglobulins, intravenous immunoglobulins, and what it does, it binds up the antibodies that are circulating and also helps promote tolerance. When you look at the clinical evidence for miscarriage treatment from the immune system, it's the one that's most studied and the one that's most beneficial. Not everyone needs it, but in people like yourselves who have these anti-HLA antibodies, you have the KIRA receptor, and you carry that HY restricting, which could potentially cause more antibodies to be formed, you want to bind those antibodies up by the embryos implanting and keep them suppressed as the embryos grow.
Ah, okay.
Okay. We do also recommend, because your history of miscarriages and the anticardiolipid antibody is to keep the inflammation down, and we use prednisone. And then finally, your nutrition. When we look at the nutrition, what we see is that we like to bring down the fatty acids by using more fish oil. And you'll see in our recommendations is that we start off at a high dose, just 6 grams, and then we bring it for 2 weeks. And then we bring it down to 4 grams for 2 weeks, and then we keep it at 3 grams for maintenance. And that will bring down your inflammation, So that way when the embryo comes in, it's not going to see that inflammation that it would now from your diet.
Okay. Would it be a prescription form? I'm asking because supplements aren't regulated. Like it could say that it's 6 grams, but not necessarily be.
Yeah, as long as you're supplementing with your diet as well. It's not exact. Okay. So that's what we recommend. And what's going to happen is that the office will reach out to you. They're going to give you a summary of the treatment recommendations. Okay. This is what you're going to get. Make sure I pull the right one here.
And then who coordinates with Dr. McConnell? Is that you, or how does that work?
Yeah, you can communicate. You can just share with her your report and this summary you're going to get. And she knows me really well. She can reach out to me if she has any questions. Okay. But the way it works is that Dr. McConnell and Columbia, they manage your protocol. We don't get involved with your clinical protocol, your FET, anything like that. We will manage your immune treatment. Okay, so what you do is once you're ready for your FET, we're going to have a private nurse. Her name is Linda. You reach out to Linda. We say, I'm going to start my estrase on this day for my FET. And she will send you out the protocol and specific instructions on the medications and order the medications for you.
Okay.
So you're going to get a copy of this, which is your summary and treatment recommendation, which we just went through and talked about. And what you're going to see, that treatment plan is going to be prednisone, which is 10 milligrams twice a day. It's an anti-inflammatory. The Lovenox, which is the blood thinner and the baby aspirin, and then the low dose IVIG. There's 2 different types of IVIG. There's high dose for people who have a lot of these antibodies, and then low dose for people who have a few, just like you do. Previously, everyone got high dose, but we've been understanding this, the cost of high dose IVIG. So the last few years, we've been using low dose.
Okay.
And having great success with the low dose. But if we see that you're with the low dose, that the antibodies are not being suppressed, then we'll have to increase the dose as needed. Okay?
Okay, and this timing would be synced when I start the estrase, is what you said, right? When I'm starting the...
Yep.
Okay. How is the IVIG administered?
It's an infusion. The nurse will help you set up an infusion. You go to an infusion center, or you can have the infusionists come to your home and give you the IVIG.
Okay.
But she'll explain all that to you.
Okay.
Now, in terms of being realistic about things, okay, inflation has hit us now, and the cost of IVIG has gone up. And if you have a shock to the sticker price for IVIG, say, hey, look, I just can't do that. One of the options that we can use is a medicine called Plaquenil. Plaquenil is an oral medication. If I tell you the other name for it, you say, oh yeah, I've heard of that before. The other name is hydroxychloroquine.
Oh my God, no.
That's why I never used it.
Oh my God. Yeah, I might have heard of that.
It's also used to bind up the antibodies.
Okay.
But it's one of those things where if you say, hey, look, the IVIG is just too much for me, we would use Plaquenil. The Plaquenil has to be started like a month in advance of your FET. So Linda will reach out to you. She'll say about some of the pharmacies, so you can kind of look at the cost. If you say, hey, look, I want to kind of start with the Plaquenil if I can, then we can start with your Plaquenil. And then once you have the transfer, we follow your levels. And once you're pregnant, we follow your levels. And if your levels are really starting to spike, then we may have to add in the Neupogen at that point. The IVI.
Yeah, okay.
Okay. But,
so I guess the sooner she can tell me the price so I can figure it out, the better.
If she doesn't reach out to you today, she'll reach out to you tomorrow.
Okay.
Okay. But you should get this today or tomorrow, the summary. And remember, this is what we recommend based upon, but I'll write in your chart that, you could use Plaquenil instead of IVIG.
Okay. And then I'm looking at these notes. So some of this says for 2 weeks, for another 2 weeks. So I should start these straight away then.
Yeah, I would start the official as soon as you can. And then just let us know, Linda's going to reach out to you, let her know about the IVIG. If you say, look, I want to try the Plaquenil. Plaquenil is very inexpensive because it's been around for years and years. If you say you want to apply, then we want to get you on that right away. But it takes about a month to kick in.
Oh, wow. Okay.
You know what I can do? I'll let you look at everything, then you let her know which route you'd rather go, then she'll order the Plaquenil.
Okay. I think I just have to run it through the insurance and see. I'd like to know what the price difference is.
Right. long as you're not having to transfer next week, we're okay.
I am not. I am not. I'm actually like, I have to go. Unfortunately, my uncle passed away, so I have to go home. So I may not make a March cycle. It may end up being April, which it sounds like will time out anyway. So
sorry to hear about your uncle, but
thank you.
It's a much better timeline for you for getting your body ready.
Yeah, yeah.
All right.
All
Where do you
right.
have to go? Where's home?
California. I have to go to Fresno.
Oh, Fresno. Okay.
Yeah, yeah.
The good thing about death, you get to see family you haven't seen in a long time.
That is true, and all the drama that comes with it.
So,
there's a reason why I live on the other side of the country.
we're both people of color, so we know that drama.
Yes. Oh my goodness.
All right, young lady. Well, it's good talking to you again. I look forward to helping you be successful. Okay?
Wait, before you go, so how much does this increase my chance of success? Like, what is the...
I can't give you overall because you're using a donor egg, right? But it's not, from what I see, there's not a lot going on, okay? We actually can calculate it if you were, say you were using your eggs and, things like that, but we can't calculate the success with that. But if we were using your eggs and you were a young donor, healthy donor age, you'd be in the above average category, which is like over 75% chance of being successful.
Okay. Yikes. Okay.
There's nothing huge or major going on.
All right. I just had to ask.
Right.
Okay. Thank you.
Okay.
All right. I'll talk to you later. Okay. Bye.
For your travels.
Thank you. I appreciate it. Bye. Hallelujah. Got my protocol. Got the protocol. Okay. Let me stop.